So let's take a little step back now and let's just think, why on earth do we need this funny React rubbish anyway? Can't we just do it all the way we always do it? Let's all just go on ALS courses and we'll come to the labs and then we'll do ALS. That'll all be fine. Let's stick our heads in the sand. What could possibly go wrong? Well, I think that cath labs are completely different to Mrs. Miggins, who arrests on ward 56, 85 years old, found in the toilet. I think arrests in cath labs are completely different to someone with an out-of-hospital arrest. That's what ALS is really set up to be brilliant at. It's set up so that you can get massage, really good quality massage, compress the heart, and then do the basics well. They're trying to increase the amount of time they're having CPR, and they don't have much else that they can do at the end of the day, can they? Bit of massage, few shocks, bit of adrenaline. That's it. We can do masses more. For a start, we're probably pretty much certain what the cause of the arrest was, because we caused it. So we know the reason for the arrest, so we can probably do something about it. So we're already ahead of the game. We probably got 10, 15 people in our cath lab area to immediately mobilise to help us. We've got really complex equipment that we're going to need: echoes, pericardiocentesis, wires, things that we can use to plug vessels, all sorts of things that we need quickly and efficiently to come into this room. So we've got to get organised really quickly. And these things aren't taught on the ALS, are they? They'll just and the Lucas as well. You're not taught how to use these things. So and then the other thing is that in your cath labs, have you ever called an arrest team to your cath labs? Do they come in and swiftly take over and sort it, or do they come in and go, oh my God, what are we doing here? And then they see a senior consultant cardiologist who's like a god to an ALS team, and it's like, I'm not going to take over for you. So they don't know how to interact with our team. So actually, calling an arrest team isn't the right thing to do in cath labs. We're the experts. They're not the experts. They don't feel comfortable. They don't know what to do. So we have to not rely on them. We have to take it on ourselves.
They do help provide the airway support.
Oh yeah, so we are going to call them, but we're calling them at a certain point, and we'll talk about that. And it's really important. We need a good person, and anaesthetist preferably for airway and breathing, especially for some airway emergencies. But in the ALS protocol, the first thing you do is call the arrest team. In our protocol, the first thing we're going to do is different things to try and save the patient. We're going to do shocks, we're going to try and do pacing, we're going to try and get the protocol going so we can maybe try and open that vessel. We've got higher priorities than ringing the arrest team. That would be my just take on that. So another thing I've just said already is that the cardiologists need to be separated from the arrest. They need to be there to be doing the expert interventions, not thinking about the mundane things that we're going to sort out for them. They want everything to happen around them. And it's really stressful. I don't think anybody here would say, no, it's not stressful when someone arrests on the table. Of course it's stressful. We have to realise that and understand it. But what is the best way to fix stress? The answer is protocols. If you know exactly what you're doing in every single situation, then it's much less stressful than standing there going, oh no, what's going to happen now? So we want a protocol for everything. Literally, we've now got one for everything in this course: arrests, non-arrests, and if you see one that isn't there, we'll make one, because we don't want to test your memory. We want to have a protocol for everything, so you know at the end, even if there's a bad outcome, you can say, I did absolutely everything I could for that patient. I did everything on this sheet just the way we practiced and trained. That's going to be really great for team stress and for knowing you've done the best in that situation. So we've got some other principles, and that harks on to this concept of having a protocol for everything. An emergency is not the time to test your memory. I am scarred from ALS courses where I was a little SHO, where you turned up, you did the course, and then you were called into a room on your own with 5 senior people, and then you had to run the arrest. And remember, it's the adrenaline after the 3rd cycle or before the 4th cycle, and you failed. You're a failure if you didn't remember that. So how crazy. I was running a course and we were doing a little asthma scenario, and I said to the guy, what are you going to do now? He said, oh, just wait a sec, and he grabbed the ALS manual and he looked it up, and I was about to go, what, stop that, and then I thought, That's brilliant, you genius. So why shouldn't you? In a real situation, why not grab a manual? And the only reason we don't is because they're not available. So let's make them available. So we've got a core sort of principle that we're going to have posters on the wall, we're going to have protocols, we're going to have flip charts, everything's available to you. You do not need to remember a single thing apart from where is it. And you have a role to decide which protocol, what is wrong with the patient, but that's it really. So it's all going to be on the wall, and it's all going to be ready and there for you. The second principle is an emergency really isn't the best time to decide how you're going to pair up doing some catheter interventions with the massage. An emergency isn't a good time to decide when you're going to stop the massage for pericardiocentesis. It's not a good time to decide all these different complex interactions when they've arrested. The time is today. The time is now with a plastic mannequin. It's very difficult to kill a plastic mannequin. And so we can practice, we can do it 5-6 times to get it right. So when it happens in real life, you'll know exactly when we're going to stop the CPR, when we're going to start it again, when we'd like as a team to put the Lucas on, when we're going to call an anaesthetist, what he's going to do, how he's going to help us. So we're going to practice it all in advance so that when it happens in an emergency, we're all sorted. And really, it doesn't take long. You don't have to do this course every month. We can all practice once a year, once every 2 years. We can do some e-learning once a year. It doesn't have to be difficult. We just tick over so that we remember it, or we just check the flip charts. But a little time in advance saves a lot of stress in a crisis. And some crises might be rare. Annulus rupture in a TAVI, you may only see it once in your whole career. But isn't it better to know what you're doing if it comes along? And just like has already been said a few times, how are we going to organise ourselves? Well, we think this is the communication board. We think you always already have WHO checklists. You get together before every case, you have a talk. So let's talk about all the important things that we might need in an emergency. And let's put it on a communication board. And we practice it really well. Leah took you through it today. There was a nice board there. And actually, when an anaesthetist came, you came in as an anaesthetist and said, right, tell me about the case. If everybody knew there was a communication board there and it was totally part of the protocol, you could have taken a quick look at that on your way in. You could have gone in and you could have gone, oh right, okay, 57-year-old male, oh God, he's allergic to Brufen and he's having a PCI. You can walk in, instantly what's going on in the room. If another cardiologist comes into the room or another person from another lab who doesn't know anything, they can instantly take a look at that. The second thing is we can put our 6 key roles on it and we can put things that we think might be important in an emergency. So we think this is going to be really important, and I don't think it'll take that long. We do a checklist anyway, so you might as well have it open and available. The thing we do badly in surgery, and I don't know if it's the same in yourself, so we've got checklists, then we tuck it away in the notes, miles away. So the difference we'd like to change to a little bit is it being on a board so that everyone can see it if something happens. So I think that's going to be really useful. So every emergency has a standalone protocol, and we'll go through those protocols with you. The protocols are going to be available and visible, so we try to put some posters up, perhaps you can have more, and then if every cath lab's got them all the time, you're walking past them every day, so you understand where they are and where these resources are. Now, we're going to have arrest and non-arrest protocol. So let's say you think the patient's having a big pneumothorax or there's a VT or something. Anybody in the room can say, this is the pneumothorax emergency, this is the VT emergency, this is the perforation emergency. Then you can just grab the flip chart, you can just activate that protocol, and everybody knows you're all on the same page, and you're just going to read it out together and do it all together.
So Joe, obviously the buy-in, when I went in, I deliberately kind of ignored the board intentionally to get the awareness. The buy-in from everyone is important because at the moment the arrest protocol for cath lab with the group anesthetists is red bell, they come, and if you're going to change this, you need to have a buy-in in such a way that you call the duty, arrest happening here, there's no bell, send the anesthetist over to help. And that sort of buy-in is kind of important from the surgical group, from the cardiology group, to have that bigger buy-in.
Yeah, no, I wouldn't want to change any really good protocol for calling an anaesthetist. So yeah, you'd keep that just the same. So if you've got a red bell system for an anaesthetist, that just stays just the same. And if you come into the room and you don't notice the communication board, then it's absolutely perfect to talk to me as the emergency leader.
Sure.
In fact, that's a really good role for me as the emergency leader. You didn't need to talk to Madhav because he's busy. So you talked to me and I sort of relayed back to you sort of what the situation was. That was a really good reason to have an emergency leader. So yeah, I'm not saying a different protocol at all for that. So that's works well. That's great.
And I have struggled before in the middle of the case. The anaesthetist comes in and I'm trying to talk to him, debrief him, but I want to get on and do stuff.
Yeah, you
It's
should
a
do
pain.
that. Yeah.
So, it's fantastic.
Yeah. So what we want, we're going to have perhaps a resource person right at the door that's manning who's coming in and out. So we don't have 562 useless people in the room. They may be able to greet you at the door and they're, all right, this is the anaesthetist. I'll give them a brief. And then if they come in and you still need information, then me as the emergency leader, you'll say to me, right, I'm the anaesthetist, just like you did. And then I can brief you as well. So we've got hopefully several sort of layers to help you as you come into the room. And I've got time to talk to you, whereas he may not have time to talk to you. So yeah, red belt perfect. But we're just trying to help you as an anaesthetist coming into these situations because we know it's really stressful, isn't it? Imagine let's say the person's got VT with a pulse and you're called in, put them to sleep. You don't know the weight, the height, the gender, the allergies. Jesus, this is dangerous. You need to know all these things if you're going to give an anaesthetic, even in an emergent situation. We've got to help you out with that. So everyone can activate the protocols, and hopefully we'll today practice a little bit with changing around roles. Different people can do the massage, the airway, the defibrillation, or being the emergency leader, or being resource commander. If we all know everyone's roles, then if you see someone, you go, oh, they should be doing this. You can just mention it, can't you? So let's all practice as a team and practice all the different roles as well. So we need an advanced leadership structure. The advanced leadership is that Madhav is in charge. It's his patient. He knows everything. He's probably noticed that they're about to arrest before us as well. He's quite likely to know why they've arrested. So he's in charge. But the advanced leadership structure is this second leader. And I just interact with him. He knows there's one person in the room that he talks to. So he doesn't have to go, where's this or where's that? He talks to me and I sort it out for him. So that's that two-way interaction rather than one person in charge of everything. So that's the sort of big difference, I'd say, that we're going to be practicing, and we're going to allocate someone for that. Now, one thing I really want to concentrate on as well is something that I think works really well. It's called active followership. So in this role, I was shouting quite a lot. I like the sound of my own voice. It's great. So I was shouting away. What I'd like from everybody else is when I say give 3 shocks, that person says, giving 3 shocks, 300 joules, because I know they've heard and I know they're going to do it. If I say do CPR, going to do CPR 30 to 2 for 1 minute. Airway and breathing, if I say you take that, you go, right, breath sounds both sides, at 100%, I'm happy with the airway and breathing. As an emergency leader, the thing that's most difficult for a leader is if everyone else isn't feeding back to you, so you don't know what's happening in a room. So whatever role you're doing, when someone tells it to you, you talk back to them. So timing, I'm going to do timings. I'm going to call out every 30 seconds. So that will really help our interactions as well. Yeah, it makes more noise in the room, but it makes for clear feedback loops, which is really helpful. And it's something that we're not very good at, is it? Especially English people, So okay, I'm going to do that. And you bring the echo machine in. I don't want to disturb. Here's the echo machine coming in. Whereas you need to come. Here's the echo man. I've got the echo. I've got the echo. So we want to know when it's in the room and when it's ready for use. So
Don't dance.
So we could do a React dance. Now I'm thinking this is good. So we'll concentrate on that. When we do the next one, perhaps whatever role you're in, when you're given a job to do, just say what you've been given back again. And then when you've done something like listen to breath sounds, just tell that emergency leader you've done it and you're happy. So we've got a series of key roles. So this is a brand new course. This is an evolution. So, we're trying out new things here. So we're trying this one out, and then, we can change it in different ways. But we started off with a series of key roles. So this one has the cardiologist at the centre. Absolutely vital, important person. But we do actually, with the cardiologist, need somebody else to be doing CPR with him. So that maybe is going to be a little extra role as well. And then what do we need to look after this patient? We absolutely need someone on airway and breathing. So the person on airway and breathing straight away goes up to the head and you talk to them. Hello, can you hear me? Obviously if it's VF, they're going to have passed out. But then you need bag valve mask, bagging, 10 breaths a minute, 100% oxygen. Now, if you can't bag, you might be having an airway blockage, an airway emergency. So jaw thrust, chin lift, Goodell airway maybe, nasopharyngeal airway, laryngeal mask, things to get air into the patient. We're going to practice that in a practical this afternoon as well. So if you can get some air in, but it's really difficult, that might be a breathing problem, because it can't be an airway problem because it's not blocked. But if it's difficult to get it in, that's your first indication that might be a breathing problem. We'd like everyone in airway and breathing to then fill the trachea as well. If it's a bit across to one side or the other, difficult to bag, trachea across, that's two signs that there might be a breathing problem. We'd also like you to try and bag, feel the trachea, and also listen to breath sounds both sides if possible. We don't want to ever miss a pneumothorax, especially a tension pneumothorax, or really a hemothorax, but it's a pneumothorax we don't want to miss because we look right idiots if we have an arrest that we don't identify for that. And the best way is to try and stop everyone just for a bit. So we might even practice, right, everybody stop, I need to listen to the breath sounds. Give it a good bag or have someone else bag, and you listen left, listen right, and then you say, right, back on, I'm happy with the airway and breathing. So it's really difficult in an emergency to hear breath sounds, but this will give us one chance to do it. Now, if we suspect a pneumothorax, then we're going to go for needle thoracentesis followed by a drain perhaps, or whatever you're most happy with, and we'll practice that. So that's important, airway and breathing. If you've got airway and breathing and it's not too bad, you might need two people to do it. As long as you've got air going in, we're not going to intubate unless you are good at intubation, by which I mean you're an anaesthetist. You should never be trying to intubate someone when you can get air in if you're not confident, because it's your most difficult intubation and you need someone to quickly and swiftly put one in. So while you may see people on this course putting one in who are anaesthetists, if you're not an anaesthetist, you should never feel a pressure that somehow that has to go in. So you just stay doing 30 to 2.
What about LMA?
So LMA is actually a really good quick emergency airway. If you're happy and confident in using it, and we'll practice it in the scenarios, then an LMA might be good if you failed to get airway and breathing with a Goodell, and if you failed with a nasopharyngeal. It's a more advanced, more difficult to put in, so try those first. But if those two haven't worked and you've tried two people, then an LMA is actually pretty good for trying to get the airway, because you're talking about someone that hasn't got an airway at the moment. They're occluded, and that is as big an emergency as it gets. So yeah, so LMA is really good idea for that. So that's airway and breathing. Then the next person we need is someone on defibrillation. As soon as you're on defibrillation, you stay on defibrillation. You don't do anything else. You don't do CPR, you don't do the crossword, you don't do anything else. You're just going to be the defibrillation person. There's plenty of people in the room, so let's just stick one person on it. And you're going to have a few important roles. We'll talk to you about that in a bit. We've got our emergency leader. Just announce loudly, you're going to be the boss, and then everyone knows you're the leader. Then we think there are two more roles that I think are very useful. I think somebody to be in charge of the drugs is really useful. They need to do timing of the drugs, when they've gone in, stop any infusions that are going in that might have caused the arrest, and also maybe if there isn't enough vascular access, they'll need to either ask someone else to get some more access or do it themselves. And I think because they're giving drugs and documenting what the time is, they might be a good person to do timing as well, because they're up next to the anaesthetist. So I think that sort of works fairly well in my head anyway. So that's, we've got an important role for that person. And then this other one, which is a sort of strange role, I think it works much better in real life, because in real life, in your control room, there are people there right next to the phones and in good communication with everybody outside of the room. But I think we need a bridge between everybody looking after the patient and everything outside of the room. So this person 6 resource coordinator, I think, is the bridge between that door, people outside and inside. One good role is when anyone's rushing in, stop, you need leads. We're going to be doing some fluoroscopy. We've decided that pretty much everybody needs leads in an emergency. Even an anaesthetist rushing in to save the day, stop, put leads on. You're not coming in here unless you've got that on. And then, while they're putting it on, tell them about the patients. So that's the resource commander's role. The resource commander's phoning people, CICU, sort of CCU, another cardiologist, sort of people we need. Maybe the arrest team when they arrive, they can welcome them, they can get them in leads because they won't have thought about that, and they can bring into the room the people we think are useful. So that's what this resource commander is going to be doing. And I envisage it as being the person on the console, probably through the window, being that person. And again, they're connecting with the leader, not having to connect with MADAF. So I think that works quite well.
Who does the compressions there? Like, does the default person?
So we've not named it in this one. We're thinking about whether we give it a number, and we might actually change it so we give that person a real number. But at the moment we're giving it, it's an additional role that we're allocating today. So it's not on this poster, but version 2 it might be. Or we may take away the cardiologist, because actually he's not actually the resuscitation team, he's the specialist, and maybe this person 1 is actually just the CPR person. So maybe today we'll call person 1 CPR. Yeah.
Those drugs and vascular access, that's a very key role, and sometimes we might need 2 people to do that.
Absolutely.
Because when you ask adenosine, nitroprusside, or any other drug, they need to go and get it and make it up and do that, and we might need 2 or 3 drugs at the same time.
Absolutely. This is a sort of way of working that we can allocate at the start, but in real life, if you're on the drugs going, I'm slowly giving amodrone and I need another Venflon, maybe we say to the emergency leader, I need some help, can you get me someone else to do vascular access? And the leader will
practically, if there's an anaesthetist in the room, I think once airway and breathing is controlled, you free up and vascular access circulation come quite naturally following that.
Totally,
it's kind of extension of what we carry on there.
And this is the human factors of how we work in real life versus the theory of simulation, isn't it? So we're going to try and set up a framework to work to, but actually in real life, we need to be flexible, we need to talk back to each other. If you're on drugs and you need someone to get back to us, you talk back to me, and then we interact. So absolutely, it's never as easy as these slides might show. So that's what we're kind of going to try and practice today anyway. So the emergency leader is going to coordinate the team. The cardiologist with an assistant just stays scrubbed doing their job because they've got lots of things they need to concentrate on. And then we're going to have the emergency team. So we'll just go through what those team roles are. So the cardiologist is not in charge. He's in charge of the room. He's ultimately in charge because his name's on the top of the patient's thing. He's got responsibility, but he's going to interact just with the emergency leader, but he's going to stay scrubbed. And he's being freed up. That his role is to not have a role, which is why we might actually take it off the post and just put a CPR person. If you're really low, one thing we haven't talked about is the middle of the night. We've talked about when there's 253 people that all turn up instantly at 10 a.m. after the MDT. So it's very different to the middle of the night at 3 a.m. when there's 5 bleary-eyed people in the room, and you might be short of people, so you might not have someone to do CPR. Maybe the cardiologist will have to do the CPR. Maybe you haven't got a drugs person and a resources person. So we need to think about that, and we have to think about that in advance.
Having a separate CPR person, and that person needs to be scrubbed up as well, is it because they need to maintain the, sterile?
Yeah, we need to look at that a little bit in our CPR, because whether you can push the drape away and just massage, we should really try that. Yeah.
So one thing that's really important about this particular unit is, I think, a lot of the fear is after hours resus. But I have to say this, having done the e-course of this, and actually is an empowering thing for the unit here, for all the people who are managers, senior physicians and nurses, is that when you do your team brief, the communication board at 2 a.m. in the morning tight leaf mate. The cardiologist may not have thought about it, but as a team, you guys has now empowered you to say, okay, so if shit hits the fan, we know there are people in anaesthesia because they've just got you down the corridor. Also, we know there are people in CCU. So I guess the point is that yes, you can say, oh, what if. The point of the whole REACT course is to empower you to say, okay, so we're going to plan this before we start. We know where our resources, because there's no point calling people at 2 a.m. in the morning if you don't know where they are.
Yeah, absolutely. Yeah, we're going to put their names on the board. You'll have the phone number of the anaesthetist on the board. If you're down on numbers, you put the name of a CCU nurse. And then if the CCU nurse, you know you're on our board, we're calling you if bad things happen. They know they need to be ready to come and sort you out.
So, well, Brian, what we thought was, if you're short on numbers, if you feel you might call the arrest team at that time.
Mm-hmm.
Yeah.
But the team leader, when the arrest team comes, needs to reallocate people and
The most
utilize
important thing is that you've thought about it before
Yeah.
you embark on something at 2 a.m.
That's right.
Yeah.
Absolutely. So air and breathing, I've told you a bit about it. So some to the head end, bow valve mask 100%, feel the trachea, listen both sides, and that's an important role. And we'll talk more about that later. So there's two sort of emergencies that you could have in an airway and breathing in all scenarios, either hypoxia with breathing or hypoxia without breathing. And they're just a little bit different in our minds. So if we have an emergency where they are actually breathing, then you just put the mask on and you support their breathing, and then you establish, have they got an airway? Is air coming in and out? Is the trachea etc. Specifically, you want to say to the team leader, I don't think there's a pneumothorax or hemothorax. If you think there is, then we're going to do needle thoracentesis followed by a chest drain. And then also, if you're listening either side, you might get, especially if they are breathing, you might get some indication, are there massive crepitations or wheeze? And that again would be a useful thing to tell your emergency team leader. So there's hypoxic and breathing them. Then the arrest situation with hypoxic and not breathing, and we've talked about that. Good airway, jaw thrust, chin lift, 2 hands on the mask maybe. If they've got a beard, then load of sleek above and below makes a really good seal that you might not be able to achieve otherwise. That was a good tip I got a few years ago. And then just as you said, laryngeal mask if Goodell airway nasopharyngeal doesn't work. Anaesthetists have a difficult airway set as well. So if you can't get any air in at all, you've tried Goodell, nasopharyngeal, laryngeal mask, none of that's working. There is actually a difficult airway set to bring for your anaesthetist to try and help you out. We probably won't be teaching you how to use all that, but you've done at least 3 things or 4 things to get that airway open in your role, which is great. So defibrillation person. So we'll talk a little bit about what our 3 protocols are, and maybe I'll just talk about it a bit in the actual arrest protocol chat, but here's the 3 just here. And then, if there's limited people in the room and your shops have failed, maybe you'd be a good person to be thinking about setting up the Lucas, or maybe we'll get somebody else. We want good clear commands, by the way, when you're doing your defib. So if there's someone massaging, you're allowed to charge up while someone's massaging, but just tell everyone, right, charging, and then everyone stand clear and shocking. Just make sure everyone's clear, oxygen's away. If they're intubated, you don't need to disconnect it, but otherwise you've got to take all that away and shock. So, and we'll talk a bit about the protocol in just a sec. We've got asystole. Now, if you've got asystole, the defib person's still important because they might be able to do the external pacing. It's there, it's ready, we can connect it and we can try some external pacing. Really super important, all defibs cannot sense and pace off the pads. So if you slap pads on and then you press the pace button, the trace goes off. I have been to an arrest where there were 2 defibs next to the patient and they said they're both broken. Both broken, every time we press pace it turns off. And it's like, oh. So, and that person didn't have the greatest outcome. So, because they were never taught that you have to put ECG dots on and work off the leads. So if we have one of these, we might have, then you put your pads on, but you need to connect the ECG dots before pressing the pace button. Of note, defibrillators are so useless as emergency external pacing. You'd really like one button, wouldn't you, to get this working? You'd want that one button to turn it on. If you haven't got ECG dots on, you'd want it to go, I've got my freaking ECG dots. But it also minimises the amplitude. So when you turn it on, no amps are coming out. So you've actually got to turn it on, remember the ECG dots, you've got to max it up, you've got to do at least 3 things in an emergency. That's not very clever as an emergency device, but we're stuck with the way it is. So what we do is we practice, so we'll be practicing that today so that you know how to do emergency pacing and tell the team when it's starting. So let's talk a bit about these big clunky devices that you see a lot but you don't use a lot. So these could be really important. In a prolonged arrest, it does better CPR. It can allow MADAF to maybe do some angiography while there's massage. Now, it is a bit difficult, but it is possible. There are several different types. You've got the Lucas. There's a little thing that looks like it's come out of someone's a garage that once they finish drilling a few holes in things, they can then drill a patient. And actually, there's something by Zoll called Autopulse that's actually fluoroscopy lucent. And that just fits around a patient, and then that's much easier to have a C-arm over it. But the backboard's quite a bit bigger, a lot bigger. So there are different devices out there. It is worth trying different devices. And if you think that's better, then get that one instead. And I'll show you some evidence on why we think this might be important. But actually, this might allow us to do a prolonged arrest and to be able to do some interventions. And it has been pretty well shown to be more effective in CPR, especially prolonged, and international guideline societies do support the use of automated CPR. So we've got to have it in our protocol. We've talked about the emergency leader, and so I won't talk too much more about that. So we've got our vascular access person and drugs and infusions. So what are the drugs and infusions? Well, in the arrest, it's just adrenaline and amiodarone, so that's not very difficult. Of note, just bear in mind that adrenaline has terrible evidence for it being any use at all. It's pretty rubbish. There's a meta-analysis in 2015 that said it doesn't really work. Then there's just been a big study in Britain called the Paramedic 2, where they're randomising ambulances and paramedics to giving it or not giving it. And they showed a 2% improvement, so 112 people you need to treat to save 1 life, but their neurological outcome's terrible. So they're all vegetables. So it's really not very good, is it, that? So adrenaline isn't great. That's as compared to number needed to treat of 5 for bystander CPR, number needed to treat of 10 for early shocks, number needed to treat for adrenaline 112. So it's not a very important drug. So we're putting it after the 3rd cycle. At the moment, the guidelines say give it every 3 to 5 minutes, 1 milligram IV. Amiodarone also has some pretty good evidence on it. There's lots and lots of randomised studies, all beginning with A, and they all show about a 10% improvement in the chance that VF will convert to sinus rhythm. Now, if you're giving it after the 3rd cycle, so you give them 3 shocks, then another shock, then another, you're down to your 5th shock. So it's not really that likely that shock's going to convert anyway without MADAF doing some intervention. So it's just a tweak. It improves that chance of conversion by another 10%. But because it's got level 1A evidence for it, we are going to use it. And there are 2 drugs in arrests. Atropine's been taken off the algorithm, you may have noticed, in 2015 because of futility of use and because of the desire to have less mucking about in your average patient on a ward. Now, that's not to say that in a cath lab, a very specialist environment, we're not going to wrestle it off people. You know, if an expert wants to use it or the anaesthetist thinks it might be an idea, you know, okay, you could use it, but we think we've got very quick and efficient access to external pacing. So we're using external pacing to get the pacing back rather than atropine. That's why it's not on. And then for the non-arrest scenarios, you've got some naloxone, flumazenil for sedation. Your anaesthetist might need some things to put people to sleep, etc. But really, we've only got 2 drugs in an arrest, so it's nice and easy, lemon squeezy to remember. Here's a little note on the resource commander. I put a little policeman there because they are the policemen into the room. They're going to stop people coming in unnecessarily, they're going to gown them up, and they're going to call the right people to help us out if possible. And that really is what I think the main reason for that person is. They might be able to stand with the flip chart and help us out to remind us what's on it to help. And they'll bring up those flip charts and things, which is great. So who's going to do the roles? Well, it'll change in every unit. You guys have to decide because everyone's different to others, but doing it in advance is really important. The REACT protocol. So we've talked about roles a lot, and I think that's because the roles and how we work together is almost more important than the exact protocol we follow, because working together is absolutely key. We need a Formula One team working fast to fix our patients. So that's our roles, but we need a really good protocol, and I think this isn't a really good protocol. I think it sucks. I think it's really good on the wards. I think it's really good out of hospital. I think it's fabulous, if someone arrests in the lounge downstairs having their organic coffee. But it kind of sucks in our cath labs. We don't want to start the CPR. I want to shock a person in VF. If we've got asystole, I want to give them some. I want to put external pacing on. That's our priority. I think non-shockable and shockers are a bit basic for us. I think we've got VF for shocks, but we can use our pacing quickly and efficiently. And we've got pacing labs. We're putting pacemakers in because they got heart block. This is going to happen a lot to us. So let's use a group of people that might benefit from pacing, and then let's put some people into the PEA group. And then all these little things, H's and T's are great, but some of them are completely pointless for our situation in cath labs. How many hypothermic patients are going to arrest? How many people is going to arrest from trauma in cath lab, unless you regard what he's doing as trauma? And so they're not useful. But tamponade, that's really important for us. Tension pneumothorax, pacemaker, poking wires into the chest, that's really important. So let's change this to our situation. Coronary thrombosis, we're doing an angiogram. Of course they've got blocked coronaries, so this isn't suitable for our purposes, so we need to change this. We identify the arrest immediately. That poster's designed for people with a bit of a delay to arrest. And we need these specialist interventions. We've got lines in places. And the other thing is, these are just designed to try and get maybe an 8 to 15% chance of survival. We should plan 50, 70, 100% survival, especially in elective patients that suddenly there's a complication. We should be saving these people. And if we don't save them, it's a problem with our organisation, not the fact they definitely wouldn't have survived that perforation of the LAD or that annulus problem after a TAVI. These are my only sciencey slides, so don't glaze over too much, they'll be over very soon. But there are guidelines out there for arrest in cath labs. They really exist. So I put what I think were the most useful ones first. The European Resus Council, I was actually involved in this as part of the team looking at what do we do different in a cath lab. So it's quite big, that's actually all they wrote. It wasn't that much, but what did they actually say? They were quite useful. They said in this special setting, it's okay to shock before massage. So let's shock before massage. Someone that arrests, just like on that table just there, they didn't need 20 seconds of massage. They need a shock. That's what they need really fast. So we're not going to massage the instant we see VF. We're going to wait. We're going to connect the defib. We're going to give them 3 shocks. Now, that's why we're going to give 3 shocks as well. Because if one doesn't work, why would you wait for 2 minutes? Because they don't need massage yet. There'd be no study proving a benefit of CPR in anyone that's arrested in less than 4 minutes. And yes, there have been studies in it. There was a study in Norway of 4,000 ambulances randomised to shocks first or CPR first. Above 4 minutes, it was better to CPR and shock. Below 4 minutes, it was better just shocking. So there's no benefit to the patient of CPR in the first 1 minute. The importance in VF is shocking them out of it. That's why we're going to go for 3 stacked shots, and that's really important. And it actually says it in the guidelines. It says, it failed, you can repeat it up to 2 times. It exists in guidelines, do 3 stacked shocks before the massage. One thing that came out a lot in the European Resus guidelines here is that they were really worried about interrupting massage when it's an established arrest to do some PCI. Because, MADAF is amazing, but it might take some less amazing people 5, 6, 7 minutes to open up a vessel. And they were very worried about hands under the fluoroscopy. And that's why they're really strong about saying use a mechanical compression device. Now, it looked really clunky there, didn't it? And it's like, oh no, how are we going to get a shot to the side of it? But actually, it's really much safer to be using it. Your hands are out of the way, you're getting good CPR when it's going to be prolonged. So I think we should be assuming in our minds all prolonged arrests should go on mechanical compression devices. That's what this guideline says. The Americans have done a guideline in it as well. Again, you've got to look very carefully to find it. They're tucked far, far away at part 10.5 of the AHA guidelines. And they've chosen to say, again, we think that you should be using mechanical CPR in this situation. And because they're American, they like really expensive things like extracorporeal CPR. So I guess I don't think you've really done this yet here ever, but more and more in the future, people are using things like cardio help, which is a fem-fem, basically ECMO circuit for someone. So if you put them on automated CPR, they're 50 years old, and this is going to be prolonged, sooner or later we might be able to call a team down and get them on some kind of ECMO. We won't be practicing that today, but just bear in mind.
When you said prolonged CPR, like what time is it?
So we're going to do 3 cycles, and then we're going to put the automated compression device on, the Lucas. And then we're probably at the end of what we're going to be simulating, but you might be there thumping, he's trying to open the vessels 20 minutes in, 30 minutes in. After that kind of time frame, you're going to start to get really bad outcomes, 40, 50, 60 minutes. So the Lucas can't just keep someone alive for longer than 30, 40 minutes. That's where extracorporeal CPR might have a role. In America, there's a unit in San Diego that uses extracorporeal CPR for every arrest that lasts longer than 20 minutes with a 10% survival rate. These are people that we'd all be giving up on. So now 90% are spending weeks and weeks in their ICU and not surviving, but 1 in 10, there's survival. So the future might be getting an ECMO device such as CardioHelp in. But I only bring it up because it's in the American guidelines. We're not going to practice it here today. You've got your own guidelines. Your guidelines talk about arrests in cath labs. So you actually do have advice on it. So they say that we should be, there's some evidence for mechanical CPR. They're saying it as well. They're saying, you should certainly be thinking about it. They say you can do 3 stack shocks. So when we decide that we're going to do 3 stack shocks, you actually have complete support of multiple guidelines. We're not going out with. So a resus officer will not be able to say to you, don't do that. 1 shock in 2 minutes is what you need. You can point to all your guidelines, including your own ones here in New Zealand. And it's actually saying you can do it before massage as well. Interestingly, in your guideline, it's the only one that I have found that specifically says, in this one, it specifically says the interventionist is going to be really busy, free them up. So you are ahead of the world in this already. That's why I'm here, because you guys are ahead of the world. And it says specifically, there may be, I love these words, there may be some tension between the CPR and the interventionist carry on the procedure, word for word out of your guidelines. So that's what this course is about, to fix that tension. So it's great, so well done for identifying that. So here's our REACT protocol, and I'll just go through it quickly if I may. So we're going to identify the arrest. VF or asystole, it's obvious they've arrested. PEA or extreme bradycardia, you need to either see the transduction of the arterial trace flat, or you might need to look, listen and feel. You might need to feel a pulse if it's a pacemaker case with no arterial line in, and it's a PEA. But mostly we're going to identify it immediately. Now, one special departure is if you see an arrest, the cardiologist is going to try and tell you what they think it was due to. So you might have heard today just there, he said, cardiac arrest, the LAD's occluded. Brilliant, so the whole team now knows why they've arrested. Cardiac arrest, I think I've perforated. Cardiac arrest, there's a vessel dissection. Cardiac arrest, I think I've caused a pneumothorax or something. So if you call out why you think it's happened, that's great. We've agreed everyone's going to wear leads in the arrest, so throw someone out if not. We've actually had a discussion about, could it be reasonable for the anaesthetist to come in and not wear leads because it's such an emergency? We think it isn't reasonable because there's just going to be a muck-up one day. He's going to be busy. You saw how close he was to the fluoroscopy, and then we just image. 20 seconds to put something on. All it is, they'll put it on. It's just they might forget. So everybody should have it. So here are rhythms that we're going to separate. So we've got our first one, 3 stack shocks. If that doesn't work, then massage for 2 minutes. So Some people ask about precordial thump. It's in some guidelines, but actually if you've got early access to a defibrillator, you might as well do defibrillation. Just one little thing I didn't say about the massage. So not massaging is great because you have a massively high incidence of rib fractures. So if you've got a quick VF just because I poked the ventricle and it comes back, if I massage them and I crack 5 of their ribs, there's a 1% incidence of a flail chest. I've fixed 2 patients with established CPR. I've got such a flail chest, they weren't extubatable because every time they breathed in, their chest sucked in. So, you can really wreck someone's chest with CPR. So A, let's defer it. And B, if you're giving CPR, we're not going to massage to 5 to 6 centimetres. We're going to look at the arterial trace if there is one, and we're going to massage to 60 systolic. So that's how much the patient needs. The guidelines specifically say 60 systolic or 25 diastolic. So we're going to titrate how much we do massage. Here's an interesting thing. You can be a diagnostic test with massage. How on earth do you do that? If you're massaging as hard as you possibly can, massive, you can feel the vertebral column at the back of the patient, and you're getting nothing on the arterial trace, then that must be a mechanical cause of why the heart isn't emptying and filling. So that might be a tamponade, or that might be a massive bleed. Probably most likely a tamponade. So if you massage massively and you don't get an output, you say to everyone, this person's tamponaded, because there's no other reason for it. So that's something that people don't realise. You can get a diagnostic test with massage. I love that. So we do 3 shocks, they don't work, we do 2 minutes. Now, we all have to think, what about doing 3 more stack shocks in 2 minutes, 3 more stack shocks in 2 minutes? Well, we thought if the 3 stack shocks don't work, something's gone really wrong with this patient. So we think it's better to maybe just now fit in with what the guidelines show, because we're going to be doing other things. I think it works better. We'll do our 3 shocks, 2 minutes, and then only do a shock and back on. And actually, really, it's going to be best if we do a shock and go straight back onto massage, because now it's getting a bit more prolonged. So let's do it a little bit more like ALS. But then after the 3rd cycle, we're going to think about the automated defibrillation device, the automated CPR device. So asystole, so we've separated this out from the non-shockable rhythms, because we think it's really important. We had a little war about this yesterday, and I think we might change this. We've said if it's asystole, get going with some massage and then connect up the defib, because it's quite difficult to set it up to do pacing. But we're a bit worried. We think maybe we could be fast. So we're thinking maybe we could set it up quick enough to try pacing before any massage. I think if we can do that within a minute, I don't think we've harmed that patient at all. So I think we're going to have both situations, VF and asystole. We're not going to do massage until we've done something with the defibrillator. So remember, if it's asystole, put the pads on, but also connect the ECG leads. Also tell the team leader, right, I'm turning the pacing on, I'm maxing it up to maximum amplitude, and then say whether it's capturing or not. If it doesn't capture, okay, stop it, you can't do anything else, don't fiddle with the pads or anything, let's go to SEEP, let's go to massage. And then you're going to go around, and every 2 minutes you're going to just recheck see if there's an underlying or not. Hopefully that's going to be okay. So the final one is PEA. Really, PEA, there isn't a quick and easy. But why isn't there a quick and easy? The answer is because this might be one of those hypovolemias or tamponades. Because the heart's trying to contract, the heart's fine, I'm all right, I'm contracting, but there's something squashing it, or there's no blood left in the system. So PEA is often due to something like a tamponade. So we're going to have to get an echo quick and think about that, or a tension pneumothorax, or something other than the heart. And so that's why we've separated this one out. And that's why we've got this up at the top. So we want, in all established arrests, we've got to get an echo probe in. We've got to get someone to do an echo for us. It can be difficult. The heart's bouncing around. The interventionist maybe can't do it because he's scrubbed. So you might need someone else to do it. But we need to get an echo probe and then need to have a look, because it's really common as a problem. We've written up here that after the 3rd cycle, adrenaline and amiodarone, and after the 3rd cycle, we're going to put the automated CPR on. I would genuinely like your feedback on that, because at the end of today, I'd like you to tell me whether that's right, or whether we should give adrenaline after the 2nd cycle, because that's what all the guidelines say. They say 2nd cycle. But I think adrenaline, I want to push all these things away, because I think they're not that important to be doing the important things, which is sorting out the CPR and doing intervention. And then the tension between CPR and the interventionist, we're trying to mandate, if you are doing manual CPR, we'll pause for up to a minute, and then you should really allow us to do a minute of CPR. Now, we've got to get that balance right, so we want someone calling out every 30 seconds or so. We'll give you, the interventionist, your minute, and then emergency team leader's got to ask the cardiologist, can we start CPR? Imagine if he's just about to fix the patient, and then you stop doing that, he's going to be pretty annoyed. A wire falls out and he can't get it back in.
Why don't we just fix the Lucas up front? I mean, very quickly in the cycle and just avoid this tension thing. The
Totally.
Lucas can keep doing the job and he can do his.
Yeah, we absolutely could do. So there is no right or wrong here because no guidelines say which cycle to connect it up.
Yeah.
So in my head, I was thinking if we can just do a quick few rounds, maybe he can quickly sort something out, or maybe we can quickly try the shocks. And then it was a bit of a faff to put it on, isn't it? But you're totally right. If we all think it's not that much of a faff, let's get it on as soon as possible. Then that is absolutely fine.
I think Lucas will be in the way of the RI.
Yeah, that Lucas device is a real pain to do fluoroscopy. So that is an argument for delaying the Lucas, because we gave him 2 1-minute attempts to go and open up that vessel unimpeded. So that is an argument for delaying the Lucas, and you've just given a good argument for putting it in early. So there isn't a right or wrong, but I think it's good to have a protocol that we sign up to. And at the moment, the proposal is after the 3rd cycle, but we absolutely can change it. And it's something we should all be thinking about. I would totally support us all, at the end of the day, deciding where we're happy with that. Because you're totally right, it's a nightmare doing angiography with that thing on, but you've now got time to do your PCI because you're not time limited.
And they've already gotten the views before, like they know that this artery is blocked and they've got the right kind of,
Yeah.
No, I think the Lucas kind of probably better to leave it to the 2nd or 3rd cycle, because sometimes, as you said, maybe within 1 or 2 minutes we can
Get it
This
done.
is pass away.
restrict the circuit, because we have the wires, we have everything. It's just a matter of getting the balloon and stent, and so it's
Make it
easier.
overkill.
Yeah, so this is something that that's the great thing about being in on the ground early with a course. You get to decide, and we'll tell the world what you guys have decided, and then that's what consensus is about, though. So because there's no randomised study on this one, we've all got to get together and decide what feels best in simulation.
So can I ask that you want us to wait CPR for 1 minute and give the interventionist to the plumbing thing?
Yeah, so we're thinking in situation which he tells me as the emergency leader, I really want to try and open this vessel, then we're going to say, all right, we'll give you a minute and we're going to call out every 30 seconds so you don't get time and attention, because to him a minute's nothing, to us a minute's forever. So we've got to tell him, and then we'd like to do a minute of massage, and then he can have another minute, then we'd like a minute massage. That's what we've come up with. The alternative is give him 2, 3, 4, 5 minutes with no massage, but after 5 minutes you get irreversible brain damage. The alternative is 30 seconds, but that's not long enough for it. So we've come to that balance, and then after the 3rd cycle you're getting on a Lucas. Bad luck. So
provided the blood pressure is more than 60 within that minute, because blood pressure does drop, right?
No, you may not have any
They
area
don't have
at all.
anything.
Yeah,
You may
we
not
don't
have-
have anything.
Yeah, you're
That's
flat.
done for
That's
the
still okay. Because
yeah, you're going to get no.
That's
unless we open a vessel.
You might get no flow,
Yeah.
so you're not going to see much, are you, in your angio? So the Lucas might at least get a little bit of flow around, so you can put your contrast in. Yeah, it's difficult, but having a protocol is better than not having one, and today's the best time to decide it.
So I think that minute is very crucial, because and it's as an interventionalist, it's nice to know that someone's keeping a time, because you can quietly drift away doing your stuff for 10 minutes without nothing going on. So it's very crucial that someone keeps that time, and I think quite often we can get it out of the way before putting the Lucas on, and down the track, like you said, there's no output to know what the hell's going on, then the Lucas can come in.
Yeah, absolutely. So we've changed the 3 boxes at the bottom. We got rid of the H's and T's. We put here the important things: airway and breathing, vital. Is there a pneumothorax? Specifically, I want to know, is there or isn't there? Circulation, I put the 4 places blood can hide. So your blood can hide in retroperitoneal or vascular bleeding. Look for puddles on the floor. A hemothorax, I want to know, is there a hemothorax? Is it stony dull and you can't hear any breath sounds? Is there an aortic dissection? Might be really difficult to tell. Maybe a bit of fluoroscopy, seeing a big huge aorta, you might see it in your angio, and then pericardial collection. Absolutely vital. We've got to get an echo and find out whether there's a tamponade. So that we've improved on the H's and T's. We've upped that. And then take a blood gas. That's an improvement on, consider hypercalapnia, hypokalemia, acidosis imbalances. We're just going to take a blood gas. We'd actually have anaphylaxis on here. We're going to talk about that a bit later. But anaphylaxis, the treatment's actually amiodarone and is adrenaline. So we may actually add that on. We've got some very specific, so we talked about that one. These are the H's that we've incorporated and the T's into our guideline. We've incorporated tension pneumothorax with toxins is just stopping any infusions, because you know they're not going to have some toxins throughout the hospital particularly, and thinking about anything we've given. Tamponade, we need an echo. The thrombosis, we're just doing angios. We've got a specific box here on special stuff. So, and we can change this, but here are the things. So, coronary intervention, PCI, most common thing. You know, we need to think about, can we get that vessel open? In a TAVI, we need to consider the ostial occlusion. It's probably the most likely thing that's caused the arrest. And the other ones, you know, is an annulus rupture causing a tamponade. But we're putting it on the poster so that we think about it. And then also, one of the H's and T's is a pulmonary embolus. Now, pulmonary embolus is quite difficult to diagnose. So as we're doing our massage, you may, if you do the echo, you may see a massively distended RV, but it's going to be quite difficult to diagnose. So we may think about it. Maybe their SATs were crashing down first of all. They were thrashing around saying they couldn't breathe. Maybe they got big coughs. If we suspect it enough, you could thrombolyze on the table. If you get them back, you may be able to do an echo to look for RV distension with a small LV. And then if they're really stable, you go to a CT. But we put it on here just to think about so we don't forget it. Quite difficult to diagnose on the table though. I thought in my head we could do some kind of clever pulmonary angiogram, but in real life I've been told that's stupid, shut up. You're not even though you've got the leads on, you're not a proper interventionist.
The chance of acute PE on the table is very, very low.
Yeah, it's
unless
really
you
low.
actually put a big clot through the
think of all
vein.
the antiplatelets and anticoagulation you've given them as well. So it is really uncommon. But because we want to put all the H's and T's on the poster, I think it's useful to put it there. We don't want to forget anything, but I want to have them specifically on that poster. So we've talked already about those interventions. Just one little note on capnography. If you're a cath lab practitioner, you're probably not that used to it, but it is really important and really useful. The anaesthetist will connect them up to capnography, and it's a measure of how good you are at doing the massage. So if you've got nice, good traces with high CO2s, your body is it's producing CO2 and it's breathing it out. That's great. If there's no CO2 coming out, your body's died. Nothing's happening. There's no perfusion, and that's a really bad prognostic outcome. And really, after 20 minutes with really low CO2s, it's very rare you're going to get a survivor. So just a little something to let you know about, because it's in all guidelines these days that you should have capnography, because it's basically equal to cardiac output in the arrest. How well are you doing? Just a little note, if you can see it on the on a pericardiocentesis, this is what your cardiologist is going to have to do. He needs to have that echo probe in his hand. He needs to get a needle. He's just going to advance that needle into the pericardium under vision, and then he's going to suck out some blood and maybe connect that to a little bag. This is a cadaveric demonstration. That's outside the pericardium, and then they need to puncture the pericardium. Imagine that's full of blood, and then they literally suck it out. You can, I don't know if any of you've seen a patient that's had a tamponade that's been relieved by pericardiocentesis. They get better really fast. Just a small amount can save their life. So this is a really important intervention. Can you do that when they're massaging massively? I think you're going to have to pause a bit to let him do this. It might not take long, and then you can follow that with a wire and put a drain in. So I thought we'd just show a little video of that, just so you know what they may need to do. Quite difficult to diagnose pulmonary embolus, as mentioned. Thrombolysis if you think, and then I guess calling those funny surgeon people for embolectomy, but you know they always say no, don't they? So that's just a little note on that. And we've got a little box on if you get spontaneous return of circulation. the person most likely to arrest who's someone who's just arrested. So this person is at phenomenally high risk of arresting again. So don't go off and have a coffee and say, well done. We need to then do an ABC assessment. What's different is they've now got an output. You can do a whole load more. So check the airway, check the breathing, listen both sides, chest x-ray, talk to them if they're recovering or intubate them, and then get an angiogram, get an echo. Let's look at maybe an ultrasound of the abdomen if you're worried about bleeding. Do a full ABC assessment of this person, because they're really high risk. If they've got a really low blood pressure, we'll think about balloon pumps, inotropes, extra lines in. So all the effort starts now if you've got that rhythm back. So, any questions? No, good. Does anyone have any questions on that?